Hello and welcome. My name is Dizon, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity. It's titled Disentangling Gendered Cancer Care, Improving Cervical and Breast Screening for Sexual and Gender Minority People. This is an activity supported by an educational grant from Merck Sharp and Dome Corporation. Today's activity is brought to you by CME Outfitters, an award-winning joint accredited provider of continuing education for clinicians worldwide. We are also streaming today's program over the CME Outfitter social media platforms. I would like to encourage all of you to also join us on our live Twitter conversation, and I look forward to your questions and comments. One last item I want to note is that today we're using an enhanced platform that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Don't wait until the end of the program to send us your questions. I'm going to be keeping an eye out for them in the question queue, and we will address your questions throughout the program. So I am Dizon. I'm a professor of medicine and a professor of surgery at Brown University, and I direct the pelvic malignancies program and hematology oncology outpatient clinics at Lifespan Cancer Institute. I head community outreach engagement for Legoretta Cancer Institute at Brown University, and I direct medical oncology and the oncology sexual health first responders program here in Rhode Island Hospital in Providence, Rhode Island. I'm joined today by two amazing colleagues. First, let me introduce Dr. Ash Alpert. Welcome, Dr. Alpert.
Thank you.
Dr. Alpert is an AHRQ T32 postdoctoral fellow in health services research at the Center for Gerontology and Healthcare Research, the Department of Health Services Policy and Practice at Brown University School of Public Health here in Providence, Rhode Island, and soon to be quite excited to join colleague of mine. And also joining us today is Dr. Gwendolyn Quinn, professor and Livia Wan MD Endowed Chair, Department of Obstetrics and Gynecology at the New York University Grossman School of Medicine in New York, New York. Welcome, Dr. Quinn.
Hello.
So let me start with our first learning objective, which is listed here. It's to assess disparities and unique healthcare needs of sexual and gender minoritized people as it relates specifically to cancer screening. Our second learning objective today is to recognize the negative impact of gender assumptive care has on patients receiving health promoting cancer screening. And finally, our third learning objective today is to dive into practice changes that the entire care team and staff can make that will have a huge impact on providing inclusive, culturally relevant, patient-centered care that facilitates anatomically based preventative cancer care. Before we dive in, I first want to get our audience involved. You should see an audience response question on your screen. You can vote now, and the question is, what is the most effective way to approach assessment of the need for cervical cancer screening? And the choices are gender, sex assigned at birth, current anatomy, and I am not sure. Again, please vote now, and we will be showing you those results as well. Here's another question to get our audience involved. You can vote now. The question is, are your patient intake forms inclusive of diverse genders and pronouns? Yeah, the choices are yes, no, and I am not sure. So here are the results. So about 30% of those taking this course right now have intake forms that include genders and pronouns. And I find this fascinating, particularly because there are so many people in healthcare who really don't give much thought towards gender and pronouns. And I'm going to ask Doctors Alpert and Quinn to join me and sort of help me decipher these results. Are they surprising to you? What do they tell us about the state of healthcare intake today? Maybe we can begin with Dr. Quinn.
I think for me, it's exciting to see that there's at least 27% yes. I think a year ago, we would have seen a much lower figure, but I think also pretty common to either say no or to just be unsure because sometimes physicians don't actually see the information that patients provide at intake.
Yeah. Dr. Alpert, I'll bring you in as well. I mean, I think it is telling that there almost 40%, like Dr. Quinn was mentioning, don't know what is contained within their intake forms. And we have had conversations about this as well, that, to change a system, you have to convince everybody that it's important to ask that question. You need to explain why. And I think part of that pushback may be that pronouns are very personal. I'm just wondering what your thoughts are about the place and the appropriateness that is embedded in a question like this of whether or not we should be asking these questions.
Right. Yeah. I mean, I think it brings up a few different interesting points. One is that we often assume that we know someone's pronouns or that we know their gender without asking them, or that we know what name they want us to use. And that when we ask about name and pronouns and when we share ours, that can really create a more welcoming and safe environment for all patients. But I think the other thing that it brings up, which is interesting to me, is that, no matter how much we learn as individual clinicians, that won't really be enough to transform healthcare. We really need to think about the systems and institutions that we work within and how we can shift those to really make them accessible to sexual and gender minority people and all people.
I think that's an excellent point. And I think during this presentation, you're going to learn about, the ways to think about gender, sexual expression, sexual orientation, because these are not synonymous. And I think they're so relevant. If we judge our patients by their appearance, we're going to be excluding so many people from feeling they have a say in their care. And we will get to that as well with presentations by both Dr. Alpert and Dr. Quinn. Let's go towards the next question here, and you can vote now as well. The question is, have you done any training or education with your entire team to make sure your office, your forms, and your encounters with patients are inclusive? And again, this is not your own, to Dr. Alpert's point, it's not your own training, but training as a group, as a team, as a unit who delivers care from check-in all the way to check-out. So I find this not surprising. And unfortunately, I think it begs the issue of why these kinds of activities that don't speak solely to physicians, solely to nurses, solely to advanced practitioner providers is so important. I think there are silos in how we learn in healthcare, and it's reflective of how disjointed the care can be actually delivered. Dr. Quinn, you've done so much work in this area. What do you think of these results?
I think they're pretty common for what we've seen in the surveys that we've done. The entire team is not trained, or they haven't been trained together, and so they might not have received the same information. Or sometimes just the main clinician, the physician, the nurse practitioner only feels that they need to be trained, and then they will train the rest of the team. But I think that's different than having an actual training that comes, externally. But very important. And then the next important step of this after training is assessing your environment and making sure that the environment's as welcoming as the people. I'm sure everybody is aware that a lot of times patients come in and they've had microaggressions or negative things that have happened to them before they ever reach the clinician. And so we want to try and avoid those so that the encounter, goes as smoothly as possible.
I think that's really sage advice for all of us, but it also speaks to something that Dr. Alpert, you and I have talked about, which is, in a lot of ways in healthcare systems, we throw so many hot potatoes in the air, expecting someone else to catch this. What is your take on this question? And, almost who should be driving this, but who should be catching this as well?
Yeah, it's such an interesting question. I mean, what I know from my qualitative research with transgender people is that, we experience, so what I know from my qualitative data with transgender people is that we often experience stigma throughout the medical encounter, starting maybe even before we walk in, but definitely a lot of people are experiencing issues at the front desk and in a public setting. So we really need to think about all the folks that we're working with and how to make care more inclusive. And then hopefully, sorry, Dr. Dizon.
No, go ahead. Sorry.
Say, in terms of who should be driving this, I mean, I think ideally we're creating collective spaces where we can all work together to figure out how to make these changes possible at all levels of care.
Mm-hmm. I think that's really an important point, and hopefully we'll really get to intimate those points more detailed later. But for now, let me introduce Dr. Alpert to provide the first set of data and instructions that will be relevant for this conversation.
Thanks, Dr. Dizon. So glad to be here with all of you today. Really appreciate getting to speak with you. So before getting into today's material, we wanted to define and distinguish some key concepts. Sex assigned at birth is a designation made at birth by a clinician who's viewing the external genitalia of a baby. So, and deciding that that baby is either male, female, or intersex. So that designation doesn't describe the person's internal anatomy, their chromosomes, or their gender. In contrast, gender identity is someone's sense of themselves as a man, woman, a non-binary person, masculine, feminine, or something else. Often in medicine and in our culture more generally, gender and sex assigned at birth are mistakenly used interchangeably. For example, we might describe the population of people on an ovarian cancer clinical trial as women, even if we have not asked the participants about their gender and only know their sex assigned at birth, or don't even know that. Another important term to think about is sexual orientation, which is separate from gender and sex assigned at birth. So sexual orientation is someone's attraction to other people. And often people who are transgender might be assumed to be heterosexual. For example, a transgender woman might be assumed to be attracted to men, but a transgender woman may be a lesbian, maybe bisexual, queer, or pansexual. So really thinking about these as distinct terms can help. Here are some other important terms which we'll be using throughout our talk. So LGBTQ+ is an umbrella term used to describe people who are not heterosexual and who are not cisgender. And more recently, the term that's been adopted is sexual and gender minority, which is also an umbrella term and really meant to encompass all people who we might not think of with specific language. So sexual and gender minorities are abbreviated SGM, and SGM is a term that I and the other presenters will be using throughout the talk. So a transgender person is someone whose gender differs from that commonly associated with their sex assigned at birth. For example, I am non-binary, my sex assigned at birth is female. Since those two things are different, I think of myself as transgender. In contrast, someone whose gender is the same as that commonly associated with their sex assigned at birth is cisgender. And from those of you who've taken chemistry, you might remember that cis means same and trans means opposite. A transgender man is a man who's transgender. Similarly, a transgender woman is a woman who's transgender, and a non-binary person is a person who's not simply a man or a woman. So as of the most recent Gallup poll, which only came out a few weeks ago, 7% of adults in the United States are LGBTQ+ or SGM. And 20% of Generation Z adults, so people born from the mid-90s to the early 2000s, our SGM. And you can see that those numbers have risen over time. And we also know that given structural discrimination and stigma, these numbers are likely the tip of the iceberg in terms of who is really a sexual and gender minority.
So, Dr. Alpert, there was actually a question that has come up, which I think as we move forward will be really important to sort of keep in mind as we frame. But do you know of any national movements that will remove gendered phrasing that's really confronting that issue of gendered phrasing from the care continuum? Are there any movements?
It's interesting to hear this word movements. I mean, that's definitely the work that I'm doing, with the community advisory board I work with and with my colleagues, including the colleagues here. And I know that there are many national organizations, including ASCO and NCCN, who are currently working to ensure that their guidelines are gender expansive, gender inclusive. But in terms of I really like that question. And I think I'm going to start thinking about my work as part of a movement. And I think that is incredibly inspiring. So I appreciate that.
Thank you.
So all that to say that most of us who are clinicians are seeing sexual and gender minority people, whether or not we know it, which is just a reminder that this work and these conversations are important for all of us to make our care accessible to all of our patients. One of the ways that we may be inadvertently creating barriers to care is through our implicit messaging. In other words, the language that we use in our forms and the titles of our clinics and the ways that we talk to patients. So we've put on this slide a couple examples. Two are names of clinics. And you can see that these two clinics are the pictures are pink, and they both have the word women. So Women's Cancer Center and Valley Breast Care and Women's Health Center. And you can imagine that if you're a man who has breast cancer or a man who has ovarian cancer, it would feel quite uncomfortable to walk into a clinic with this sort of a logo. And similarly, if you're on a train in the UK seeing this ad about prostate cancer and you're a woman or a non-binary person, then you would likely not think that it applied to you. And even worse, you might get the sense that people don't know that transgender people exist. Similarly, when we talk about women's cancer or men's cancer, we are implicitly excluding transgender people from our language. And additionally, we're also using language that's inaccurate, because if we think about anatomy and gender as distinct constructs, then there really isn't any such thing as a woman's cancer or a men's cancer, except that women and men and non-binary people all get cancer.
So Dr. Alpert, there was one other question that has come up. Do you think there are regional differences in how inclusion is approached, say rural versus urban or the North versus the South?
I mean, I think that it's easy to think that the Midwest or the South might have more challenges in terms of inclusion and safety. But we also know that, transgender people are experiencing stigma and discrimination and violence, including in large urban areas. So I think there definitely may be differences, but I don't know that they've been well captured with our research. And I do think that sometimes we make certain assumptions about what those differences are that may be incorrect.
Similarly, it's interesting, we talk about intersectionality, you and I personally, and Dr. Quinn, please join if you have any comments as well. But it does change that dynamic when you start to see a person and not just their gender, but it's not to say that gender can serve as a barrier, but can you comment on perhaps how it's really important to think about the person in terms of race, ethnicity, socioeconomic status, and how these all really play together in disparities?
Yeah, so we know that, when someone has multiple marginalized identities, instead of being additive, those experiences of stigma and discrimination can be multiplicative. So in other words, people can have extremely different experiences based on the intersection of multiple identities. And we know, for example, that The barriers to health experienced by transgender women of color are very different than those experienced by white transgender people.
Yeah, great. Thank you.
I could just add, I do think that there are differences, but as noted, not in the way we might think. So sometimes it's in terminology. So there's some terminology that I've noticed as a Floridian coming to New York that is not okay in Florida, but is okay in New York, which I think is okay. And it's something that I'm sure will come up throughout this presentation, that this nomenclature changes. Sometimes we jokingly say on a daily basis, but the fact is we need to be open to asking patients and their support people how we should refer to them, what terms we should use that may feel okay to them, even if they're not part of our everyday language.
You know, I just had a conversation with somebody around cultural humility. And it kind of speaks to that purpose, where sometimes our organizations will say, we want a workforce that's culturally competent. But someone said to me, that implies you can take a test or a 20-minute course and you can check off a box. But the humility that Dr. Quinn, I think you're speaking of, is where you actually ask the person in front of you, how do you want to be addressed? How do you see this disease, this world? You know, how do you see your experience, and how can I foster that rather than confront it? You know.
I think in many ways, medicine is used to its own systems of classification, and it really takes a lot of work to shift the way that we're working with patients to be humble and to really listen to their experiences and be with them in those experiences. But I think it's a beautiful and transformative thing when we can do it.
Yeah, I agree. Sorry, Ash, I will try not to keep interrupting you.
Feel free. I'm enjoying it. So this does speak a little bit to Dr. Dizon's question earlier, but the reason that I brought this slide up is because it's particularly problematic in oncology spaces and cancer screening spaces that we can be exclusive of transgender people, because transgender people experience systemic oppression and violence that may lead to increased cancer risk. And you'll notice, I'm going to read out some statistics, and you'll notice that in some cases I'm specifying or particular demographics of transgender people, because these numbers are very different across different demographies. So 1 out of 2 transgender people face verbal harassment in schools, and 1 out of 4 experience physical assault. 1 out of 5 trans feminine people will be incarcerated in their lifetimes. 1 out of 3 transgender people were fired in the last year or experienced some other mistreatment in employment settings. 1 out of 3 transgender people have experienced homelessness. 1 out of 3 live in poverty. 1 out of 2 experienced sexual assault in their lifetimes. 1 out of 3 had a negative experience with a provider in the last year. 1 out of 5 participate in underground economies, including sex work. Nearly 1 out of 2 Black transgender people are living with HIV. Nearly 1 out of 2 transgender people are currently experiencing mental distress, and nearly 1 out of 2 transgender people will attempt suicide in our lifetimes. So the reason that I bring these things up is to try to paint a picture of social determinants of health and interlocking factors that may increase cancer morbidity and mortality for transgender people. For example, high rates of HIV and HPV are associated with cancer. So there are some malignancies in particular that are associated with these viruses. And then we know that high rates, that mental distress and mental illness is linked to increased cancer mortality. Therefore, there are multiple ways that structural oppression and violence may increase morbidity and mortality of cancer among transgender people. So to give more details about the experiences of stigma and discrimination in healthcare, sexual and gender minority people experience denials of care, lack of recognition of family members, harsh tone when speaking, which I would call harassment, and also being touched inappropriately, which I would call assault. And you can see that as compared to cisgender SGM people or cisgender sexual minority people, transgender people are experiencing much higher rates of stigma, discrimination, and refusal of care by clinicians.
So Ash, there is I'm sorry, Dr. Alpert, there is a question that actually speaks towards the slides you just mentioned, and it is your thoughts, and almost, it's almost obvious, one could even say, in the current culture, but why do you think there is so much more hostility towards trans people compared to LGBTQ plus people?
So Tonya Poteet has done some very interesting work about this question. And her qualitative data suggests that part of the reason that transgender people face so much maltreatment in clinical settings is because, clinicians aren't taught about transgender people in medical school. So when trans people come into clinical settings and often know more than their clinicians about their care, it really upsets the power differential and the dynamic, and calls into question the expertise of clinicians. Mm-hmm. And it seems like from her data that clinicians often respond to that by othering and stigmatizing patients to reinforce the power dynamic. So I think that's
fascinating.
One reason. Yeah.
Mm. All right. Thank you.
So given these negative experiences with clinicians, transgender people don't present for needed healthcare, both because they fear mistreatment and also because they can't afford it. And these barriers to care likely lead to delayed presentations of cancer. And we have some early data that suggests that transgender people present with later stage cancers than cisgender people. And this likely leads to increased morbidity and mortality from cancer. So I'd like to present some qualitative data, some words from patients to exemplify some of the barriers to care that we may be creating for patients, both because our language may be exclusive and because our facilities may be exclusive to patients. So a Latina trans woman in one of my studies explained her difficulty with intake forms. I know we're going to be talking about intake forms throughout this talk. She said, starting with how to identify, you don't have options during registration. It's easy for me to sign in as a woman, but then the provider ends up asking me inappropriate questions. For example, when was my last period, or if I might be pregnant? And you can imagine that if someone's asking you the wrong questions, then it's going to be very difficult to tell them, actually, I have a prostate, or actually, I need this part of my body to be screened for cancer. So this becomes quite problematic for cancer screening. Additionally, our facilities may also be exclusive of patients. And this quote is from a white non-binary person who said, I needed to have a lot of follow-up mammograms until I had top surgery. And pretty much every time that was an aggressively gendered experience, to the point of, no, I'm not putting on that pink floral gown. You can't make me. You can do it in nothing. I'll put on this wrap I have, or you can get me something else, but I'm literally not doing this. And having to push back really hard against, I don't want to change in the special women's changing room. I don't want to hang out in the special girl mammogram ward. Thanks. And so you can imagine that for a trans person trying to access breast cancer screening, there may be multiple barriers and also multiple ways that experience can end up being quite traumatic. So the language that we're using, our patient education materials and our intake forms, our recruitment materials, may be having the unintended effect of excluding transgender people and worsening outcomes.
So Ash, there was a couple of questions related to this particular area. Yeah. The first would be, for the patient who answers female, how do you ask about pregnancy or anatomy and not assume body parts are present?
Yeah, so we know that, just to back up, we know that people prefer to answer these questions either directly with a clinician or on a form and not with the front desk. And so sometimes—
That's an important point.
So sometimes what institutions have been doing, and what one of my colleagues is exploring, is doing anatomy inventories, which is literally just a checklist. So you can just check off what anatomy you have. And so the clinician can know what needs to be screened. But I know that there are some intake forms, for example, at a former institution of mine, that really link gender and anatomy in a way that makes it very difficult to answer questions. For example, for women only, when was your last period?
Okay.
Yeah, so it might make it really difficult. I mean, you'd have to like cross things out and write on the side. And you know, I know that when I go to the doctor, it's usually a pretty stressful experience. So I don't necessarily want to call more attention to myself than is needed. So it may be very difficult to share some of these things in that setting.
Thank you.
Yeah, so even when clinicians are incredibly well educated and doing everything right, we still have barriers to cancer screening for transgender people. And this slide demonstrates a pop-up, which one of my colleagues saw when she attempted to document that she had done a pap smear and also removed an IUD on a transgender patient. So in other words, it's not just what's going on with us, but also insurance-related barriers and electronic health-related barriers that make it difficult for transgender people to get the cancer screening that we need. I wanted to end my section of the slide deck with a way of thinking about cancer screening that's anatomy-based and pretty simple. So we've put up here, you know, breast, cervix, and prostate cancer screening guidelines, and these are based both on evidence and for transgender people more on expert consensus. So if a person has endogenous estrogen, in other words, if their body is producing significant amounts of estrogen, then that person should have a mammogram starting at age 45 every year. And all of these guidelines are not including for folks who have a history of cancer, a strong family history of cancer, or a genetic mutation that increases cancer risk. Those would be different. And then if somebody is taking estrogen, if they're getting exogenous estrogen from the outside, and they've been on it for 5 or more years, they should have a mammogram every other year starting at age 50. Cervical cancer screening is the same for everyone who has a cervix. It should begin at age 21 and follow national guidelines. If that person is on testosterone, that should be noted in the message to the pathologist. And even if somebody has had a cervix removed, if they have a history of high-grade lesions, they'll still need screening. In terms of prostate cancer, if somebody has a prostate, the clinician should engage in shared decision-making with the patient about PSA testing and prostate exams. And then, oh, sorry, Dr. Dizon, were you going to say something?
Well, there was actually a couple of questions that got to the heart of how to bring it up. How does one discuss breast cancer screening in non-binary patients? And how does one discuss cervical cancer screening for someone who is trans?
Yeah, so, you know, I think you brought up, Dr. Dizon, how important it is to ask people how they refer to their bodies. So I think that can be a really good opening way to talk about these things. So how do you describe the anatomy that you have that may require screening, I guess, is one way to do it. And then really mirroring that language back with patients. And then, you know, I think that if you're not doing an anatomy inventory on a piece of paper and you're asking someone, you know, you could ask them, like, are you taking estrogen? How long have you been taking it?
Yeah.
And I think, you know, asking about anatomy, some people might want you to talk about chest cancer screening or chest screenings, and some people might be fine with the word breast. So I think it really makes sense to ask people.
Yeah, I think that's a really great, you know, most electronic medical records do allow for anatomy inventories. But the question then always comes back, well, who's supposed to give the inventory? And unless it's available on the portal side, where the patients can actually access their medical records, fill in their own demographics, fill in their own inventories, it becomes a real problem. Well, I'm not going to do it. You're supposed to do it. And, again, it's that concept of that hot potato, who's supposed to take it. One last question I thought I'd ask you before we go to the survey question is, one of the areas that really hasn't received much in the way of study, but almost get drowned out in a conversation of when you talk about sex and gender minoritized people or intersex folks. Where do we bring them into the conversation? What do we know about their experiences?
Yeah, and I'll start by saying that in some ways, this is out of my area of expertise. And I really look to folks who are intersex and folks who are doing this work to share more about this. But I think that one benefit of disentangling gender and anatomy is that we can talk about how, we think of anatomy as very binary, but really it isn't that binary. And that I think the numbers are something like 1 in 10 births are not binary like this.
Right.
So I think it's important to think about like bodies in addition to gender on a spectrum, and really try to make room for all of us in the ways that we're talking about these things.
Yeah. And 2 last questions for you, and then I would love to bring Dr. Quinn in as well. Are there cancer screening recommendations for those who have surgically constructed genitalia, or do we default to the ones you just reviewed for us here?
Surgically constructed breast tissue?
Genitalia.
Oh, genitalia. Sorry, I was not looking carefully.
Yeah.
So I actually don't know the answer to that question. I hope
there's a lot we don't know yet.
Yeah.
And we need to start by just addressing everyone openly. But I guess the last question I had was regarding an editorial wrote, and we won't have to get into all of it, but it was really around this concept of sex being assigned at birth, and how some of the controversy was really around this concept, and you just touched on it, of biologic sex, that someone is born with a biological sex. And then in their minds, it's so separate from gender, and some of that resistance. It just reminds me again and again how until we start from the same terminology and definitions, this is continuously going to be the issue.
Yeah, I mean, I think it's really important to think of all of these things as constructs. Like if we think of sex as this like immalleable, innate quality in a person, then I think it really, and that is connected to gender, and inextricably connected to gender, then I think it's very hard for us to accept and include trans people and intersex people in the ways that we're talking about things. Yeah. And that if we're really able to shift these ideas and to understand that sex, just like gender, is a construct, that I think it would allow us to change these spaces and open them up. Yeah.
Dr. Quinn, did you have any comments on that?
Yeah, I was going to kind of go back to one of the first thoughts that you presented, as an example. So even someone who has a neo-vagina, which I'm not even sure that's the best term to use, but someone who's had a constructed vagina, even if that does not need cancer screening, it's still, that person may still need other care for that part of their body. There could be urinary tract, other things that are happening. And one of the things that we've noticed with our attendings and residents here is that nobody ever had any training in examining a neo-vagina when there's also a prostate there, because it won't have felt like other things. And so people may withdraw from providing that care, not because they have a negative feeling towards that person, but they feel untrained and ill-prepared to provide that type of exam.
Yeah, there's so much we still have yet to do. Thank you for that, Dr. Quinn. Let's move to the next survey question. And thank you, Dr. Alpert, for that wonderful presentation. Let's take a moment then to get the audience involved by revisiting this question. What is the most effective way to approach the assessment of the need for cervical cancer screening? So I think it's wonderful that pre and post, the correct answer of current anatomy did increase with Dr. Alpert, your presentation. There was still several folks around the same proportion, about 26, 27%, who feel it was still approaching sex assigned at birth. I find, and Dr. Quinn, I'm going to bring you up as well. I find that terminology is quite triggering for a lot of people when you say sex assigned at birth, because they believe, or they're coming at it as it's innate, that the biology you're born with is the sex that you have. There's no, quote, assignment. But the way that I sometimes will explain to folks is that your genetics is based on your chromosomes. And I don't think any of us go through that. When a baby is born, we take a look at the genitalia, we assign the sex based on what we see. That's all it says. But again, I feel it is something that it's not natural language. I don't know, Dr. Quinn, your thoughts on that?
Yeah, I agree. I mean, even in the case of a baby born with intersex condition,
right,
until very recently, we asked parents to pick a gender to raise that child. I think that now we're offering different types of guidance, such as, kind of raising the child agenderedly and allowing them to make a choice on what they feel. But until very recently, yeah, I mean, so much of obviously cancer care that we're talking about tonight, but so much of the world is gendered in terms of what toys we think a certain child would like to play with. I'm going to talk about this later, but the bathrooms or restrooms that we may enter, and this is even listed. I was on your airplane ticket. You have to have a gender that goes along with your legal name.
Yeah, fascinating stuff. But I think it's very nice to see that there was an increase in the correct answer on this question. Dr. Quinn, I'm going to turn it over to you for your presentation.
Yeah, thank you. So this is a good segue because I really like this approach about looking at things pre and post. And I'm going to share a little bit about a national survey that we did of oncologists. So we specifically surveyed oncologists who are aligned with an NCI designated cancer center. And because we had done a single site study first as a pilot, we learned that people felt differently at the end of the survey than they did at the beginning of the survey, just like we saw with our participants here. People wrote in the comments in our little pilot survey, wow, I realized how much I didn't know. So the way that we did the national survey, in which we intentionally tried to make sure that we surveyed people from all geographic portions of the United States. So we oversampled in the South and the Midwest, in areas where there's actually less or fewer NCI designated cancer centers. And so we asked people a series of questions about whether it was important to know about sexual orientation, gender identity, their comfort in providing care for LGBT people, and then their comfort in providing care for trans people, and how knowledgeable they felt. And it was interesting that you can see that by time 2, which was when we asked this after the survey, people's perception of their knowledge for LGBT and LGBT people and trans people went down. And in a lot of cases, you would say that's terrible, that knowledge decreased. But to us, it was wonderful because it showed that people were willing to accept that by being asked a series of questions, specific knowledge questions, and not being sure of the answer, that could go down. So people are becoming aware of what they don't know. What was a little bit alarming, and we can talk about how people feel about this, is At the beginning of the survey, we had 75 or 70% of the people who would be willing to be listed as an LGBTQ provider. But at the end of the day, knowledge for both LGBT and trans people was relatively low. So it's great that people are listed, willing to be listed as a provider, but they might not actually be knowledgeable enough to be a provider. And it's also interesting to see the stark contrast between comfort in caring for lesbian, gay, bisexual people versus comfort in caring for trans people. And I want to emphasize that this is not a values-based. It's nobody said, well, maybe 2 people in the entire survey said something that appeared to be values-based. It really was, as I was mentioning before, they didn't get training in medical school. They didn't get training in residency. This was not modeled for them. And many people had actually never encountered or were not aware if they'd ever encountered a transgender person receiving cancer care. We also asked a similar question that you all were asked tonight about whether or not the intake forms at their practice collected sexual orientation and sex at birth and gender identity. And you can see that, quite a few, 25% people roughly were not sure, but the majority of people thought no, that neither of those were being collected. The most common thing that people believe were collected were sex at birth, which is often all anybody asks, or all intake forms used to just say male, female, man, woman. So quite a lot of people have investigated what the problem may be in asking sexual orientation and gender identity, which we shorten to call SOGI questions. And multiple studies have shown that most patients are comfortable asking or providing SOGI responses. Also, it was shown that just like income, people want to know why you want to know. If it's relevant to my care, I would like to tell you this information. But if you're just collecting it for the purposes of bean counting to report elsewhere, and it doesn't have an impact on my care, I might be less willing to give you this information. So across age and identities, and this was even true of heterosexual cisgender people, they felt that this question was important and they were willing to answer it in the future. And a study done by the Veterans Administration among veterans also showed that almost 100% were willing to complete these SOGI questions. And there has been, as I said, multiple other studies that showing that patients think that providing their sexual orientation and gender identity is important, and they're willing to do it. The only thing that people are hesitant about, particularly sexual and gender minority people, is, again, what's going to happen to this information? Is it going to prevent me from getting good care? And are there going to be negative consequences? And so when there's trust, either in the clinician or in the institution, people are willing to provide it. You will find studies, and within your own practices, older heterosexual cisgender people who do wonder why they're being asked. We've had here at our cancer center people say, I've been coming to you for 20 years and now suddenly you're asking me this. But again, just with a lot of things, if you explain why it's being asked, then people are happy about it. The other point that is important to talk about is that both sexual orientation and gender identity can be fluid. So a lot of places, it's all we can do to just get this information asked one time. But in an ideal situation, we'd be asking it at every patient visit. And we would be informing people that we're not making judgments about you or that your status may have changed. We just want to provide you with the opportunity to let us know if anything has changed about your sexual orientation or your gender identity. And it's also okay for things to be fluid. So one of the things, as I mentioned, that on the intake forms is when they only ask male, female, or worse, it says male, female, other, because that is othering and nobody wants to be othered. So you can offer lots of options, or you can expand on the other option to say some other term, please provide it. And that is less othering than just the checking a box for other. As we talked about earlier in the session, especially some electronic patient questionnaires that are linked to a skip pattern, if you put down your gender as woman, you may only get questions that the system believes are relevant for people with what we would call female anatomy. And so we have to be careful about those questions and how they might be given to people and or not given to people, and we miss important information. There's also a great deal of opportunity to degender the language in there. So instead of, if, for example, in a pediatric setting, saying who is the mother and who is the father, who are the parents or who are the caretaker, you don't necessarily need to ask people about their social status as being married or not married. They can have a spouse. They don't need to have a husband or a wife, all sorts of things that are inclusive. And asking patients pronouns. And I try to teach the medical students that the best way to ask pronouns is to lead with your own. You'll notice that we put our pronouns in by our names in here. So if you walk into a clinical encounter and you say, hi, my name is Gwen, and my pronouns are she, her, or you wear a pronoun pin, which a lot of us have that, can kind of pave the way for talking about pronouns. And patients may prefer to be called a different name than their government issued name. It may be a short nickname that's related to the name that is their legal name, or it may have nothing to do with their legal name whatsoever. But these are important things to gather in the patient encounter to create trust. So taking a patient history is also a really important way to get information. We mentioned asking the patient how they refer to certain parts of their body. And that can be important when we're taking a sexual history to use those terms. People might not feel comfortable with the actual anatomy that they have. They may be in the process of changing that anatomy, or they may not be, but they may refer to it with different terms than we do. Some of our attendings have said they're not comfortable using the terms that they're given. And so that's something that may have to be negotiated. So I'll give you a very crude example. A patient was asked how they referred to their genitalia, and they said, I refer to it as my birth defect. And the attending was not comfortable incorporating that term in there. But they did take the initiative to say, that doesn't really feel comfortable to me. Can we agree on something else? And they did come up with something.
So Dr. Quinn, let me just ask you one question because it's come up and it's a relevant question. And I'm thinking about conversations with my own staff. What is the purpose, though, of using a pronoun? Is it to make sure the person knows what sex you identify with?
I think in giving your pronoun, you pave the way to say, I want to know about you. And I want to understand if somehow with this information, perhaps I have limited information on the intake form, but now I'm in a face-to-face encounter with you, it provides an opportunity for me to know how you identify. You might have she or he pronouns, you might have they pronouns, you might have no pronouns. I've seen patients who say, I just want to be referred to by my name. And you have to speak a little bit more slowly and choose your words carefully to make sure that you honor that. But I think it's a great way to show that I am honoring how you feel about yourself and how you.
And I think, yeah, I agree with you. I think it does create that space for patients to express themselves. The other thing that I've seen, and I think it's something I'd caution about, and maybe you can comment on, is guiding the conversation of pronouns based on sexual appearance. That, oh, this is not a straight person. Let me introduce them with my pronouns.
Yeah, definitely. I think it's also helpful to do that in every single patient encounter and not just those ones that you think may be. Obviously, if it's a new patient, for sure, it may be a little bit more challenging in a patient that you already have a relationship with. But yes, not making an assumption for any number of things. Sometimes some of this misgendering happens when the patient's calling to make an appointment and the intake person thinks they hear a male voice and just writes that down. And so there could be misinformation that's following them into the encounter and they've never had the opportunity to give it. So yeah, it's important. Some people won't care about it, or they might ask, why are you asking me this? I've seen you a number of times, or I've been to this practice a number of times. So just saying why it is important. And if it isn't an issue, move on to something else.
Perfect. Thank you so much.
Along those same lines about making assumptions, we don't want to assume that any type of relationship about a person who may be accompanying the patient to their visit. So I know now that with COVID, sometimes people cannot have a person accompanying them. Sometimes they can, but it's always good to ask, who is this person here with you today? How are they? What's your relationship with them? I've seen, women who identify as gay, they'll come in with another person. It is not their partner, it is their ex-partner. But they still have a friendship and a relationship that they want to provide supportive care to each other. Don't assume, again, we're talking mostly about cancer, but in my world, with pregnancy, do not assume that the person who is accompanying that person into labor and to prenatal care visits is the father of the baby, or their sperm was used to create that pregnancy. So just ask who the person is, ask what their relationship is. And I think that also conveys messages of inclusive environments, that we don't just assume. So some more examples about gendered spaces in terms of the environment. You've seen examples. I mean, breast cancer is so pink, and not a comfortable setting for people who identify as men who have breast cancer, or for trans men who may have breast cancer. When our patient materials show a white, seemingly cisgender heterosexual couple speaking to a white, seemingly male physician, we do not convey that we are an inclusive practice setting. I see that a lot in cancer care about sexual health. It will say, talking to your partner during, chemotherapy, and they'll show a white man and woman on the front. And so if you are of a different race or ethnicity, if you are not in a heterosexual relationship, you're not going to pick up that pamphlet because it doesn't look like it's for you. So there's a lot that could be done with colors, with the way the furniture is arranged, with photos, with having gowns that are very gendered, as you saw, pink gowns, blue gowns. The best thing, I think, is to show that you have an inclusive environment is having either all gender restrooms or private restrooms that are not labeled. Some people have family restrooms that allow for 2 people, for someone who might need help in the restroom. But having male and female, ladies and gentlemen, all of those things, I think, do not convey an image of inclusivity. We all know what rainbow pins are. It's great that people wear them, but I think it's worse if everybody's wearing them if they haven't had any training behind them, because a patient may see that and think they're coming into a very inclusive environment. But if people have not been trained, it may send a mixed message. Certainly advertising things that's done in websites and social media feeds can easily convey whether or not it's open space. And you see a lot of reproductive endocrinology spaces now intentionally, I would say, marketing towards sexual and gender minority populations.
So Dr. Quinn, this question came up earlier, but is there a nationally known symbol, though, that can be used to let LGBTQ plus patients know they are looking at a friendly provider space, something beyond just the rainbow flag or the rainbow pins, which you mentioned?
Yeah, I'm not aware of one. Maybe Dr. Alpert or someone is. I do know there's also the Human Rights Campaign, and we have done several studies using that symbol, and nobody seems to know what it means. So I don't know. I'll turn that over to my colleagues to say if anybody is aware of something other than the rainbow flag universal.
Dr. Alpert, any thoughts on that one?
There's something that I think is called the progress flag or the equality flag, which is like a combination of a rainbow flag and a trans flag.
Mm-hmm.
So it's like you see the rainbow flag and then kind of in the corner is the transgender flag colors. So I think that's meant to be really inclusive of the whole community.
Interesting. Thank you.
So to underscore a point that we've made several times, it's really important that the entire team, from the valet who may park your car, or the parking lot attendant, the security guard, to the front desk people, because sometimes some negative encounters have happened, and by the time the patient comes to you in the exam room, they're upset, they're nervous, and they don't feel safe because of some encounters that have happened along the way. So not everybody needs all of the same information, but general information is important for every part of the cancer care team.
And I think that, Dr. Quinn, just to interrupt you, I think that is the point you were trying to make with to just stick a rainbow pin on your entire team and not provide them the training that goes along with that is it's almost a situation that sets you up for these kinds of very negative experiences, don't you think?
Yes, I think so. I mean, people may not even be aware of, they were just handed a pin and they've put it on their lanyard because everyone else is doing it. And if they do have some bias, I think it's important to create opportunities to correct those biases, or at least become aware of those biases. And something else we've talked about is, now I'm blanking on the term, but you as a clinician, you do not have to provide care for anybody who's asking you to do something that you don't feel comfortable with. Conscientious objection. And I think it's important that we assess our care systems, because somebody who has a bias towards sexual and gender minority people, we do not want them to see an LGBTQ patient any more than a patient wants to see that provider. Right. So that's another thing. And there's some people who we're never going to change. I always say that people are segmented into, there's a group of people who just think they don't need to know SOGI because they're a good doctor and they treat all people the same. And so they need to be educated to realize that not everybody needs the same treatment. We need equitable care, but not equal care. And they're open to realizing, oh, I should have thought about that differently. And then there's some people who are open to, I don't know and I want training. And then there's some people who just, for whatever, religious or value-based reasons, are going to view this community negatively. And we need to find those people and put them someplace so that the community does not have to see them.
So, Dr. Quinn, this question came up and it's highly relevant. Someone asked, what is the best way? And I should actually also include, should you? But what is the best way to discuss with a supervisor, a peer, or a subordinate their resistance to using inclusive language?
I think it really comes from the top, from the organization. Yes. So, which is so important on so many levels, because if you don't have buy-in from the cancer center director or, the board of directors, none of these things will happen. You won't have SOGI on your intake forms. We recently had an encounter where a trans man came to give birth at our hospital, and a member of the staff refused to address them in anything other than mom, and they were fired because we have policies in place that say, these things have to happen. So policy is another really important thing, because it's important to be patient facing for patients to know what they can expect, but it's also important for employees to know these are the policies. If you can't follow them, you shouldn't work here. And if you don't follow them, this is what will happen.
Mm-hmm. Thank you.
So just to kind of recap, it's important to collect sexual orientation and gender identity information, but also if it's collected, it has to be used. It shouldn't just go off into the abyss somewhere. And something that we know is a problem with a lot of systems is that patients may fill out really long electronic intake forms, but maybe all that information doesn't make its way to the clinician in the encounter. And so I'm sure you've all had the experience where you know that the patient has filled out a form that says chief complaint, but still you ask the patient when you walk into the room, so why are you here today? And the patient is like, man, I wrote that down 3 times in 3 different places, and I told 4 people before I told you. So again, I think it's important to lead with, you probably told this to other people. You probably wrote this down, but I want to confirm why you're here today. And so that may be the same thing. They might have given their pronouns or their preferred name on some other document, but you just want to check that. And I know it takes a couple of extra seconds to do those things, but it's important, I think, to do. And also to take into consideration screenings for the cancer screenings for your patient based on an inventory, an anatomical inventory. And also consider that, at least as of right now, we don't have data to suggest that in most cancers that current or prior hormone use is going to have a significant difference for people while they're on their cancer care. And obviously it needs to be decided on a case-by-case basis, but in the absence of information, I'm going to say, and I'm very happy to hear different opinions, patients should be allowed to continue with their hormonal therapy during their cancer treatment, or it should be shared decision-making about the pros and cons of that during the cancer treatment.
So just one question for you regarding the collection of gender and the actionability of that. Several folks have asked, if a patient does not provide their gender, is unwilling to provide their gender, or say they respond to pronouns and say they use they, them, how does one thoughtfully approach screening in that kind of a population? And I would say also, if someone also does declare themselves intersex as well, how does one approach that conversation with screening thoughtfully?
I think it's important to say, currently our data collection tools don't have an organ inventory, but I'd like to do that with you. And also, also clinicians, I think, need to be mindful that even cisgender people may not be aware of the anatomy that they have. And I'm sure those of you in gynecology have, asked a cisgender woman about a vulval pain versus vaginal pain, and what is that? So we have to be aware that we might be educating also, and that patients may truly not know. I know I had my tonsils out as a child, but I'm not sure if I had my adenoids out too. And I get asked all the time, keep forgetting to ask my mother. So it's kind of a shared discussion that needs to happen, recognizing that people might not know because they might not be familiar with this high level of medical jargon and terminology. And to say, here's why I'm asking you, because I want to figure out what cancer screenings you should have, what you don't need. And that also, a lot of that may be based on family history. So, if someone has a significant history of breast or chest or prostate cancer, regardless of how they identify and what anatomy they have, you might be recommending different cancer screening for them than someone without that significant family history.
Right. Thank you. Yes, I agree with you. I think the anatomic inventory becomes even more critical in those kinds of situations for sure. Thank you.
And some intersex people, for sure, they could have, as Dr. Alpert was saying with the trans people, they could be more informed about their condition than you as a clinician ever could be, because they've lived it their whole life, or they could have been, raised in a family or with limited access to healthcare, that they really don't have a good handle on what's happening, or they were told, we'll deal with that when you're older. Without access to medical records, you both may be in the dark.
Right. So, Dr. Quinn, I am going to let you finish without my interrupting you so that we stay on time.
Okay. So I'm just going to reiterate that, the collection of this and the way that it's asked can facilitate patient communication, the appropriate screening and counseling, and that high quality care is patient-centric, so that decision-making doesn't just happen on behalf of the provider, and that we hopefully can work towards creating algorithms in the future that develop tools that are supportive for this. And so in our next slide, again, we're just kind of in confirming things that we've already said, that to use sensitivity when doing a medical and a sexual history, and also communicate the privacy and this that you will honor and the sensitivity of that information that patient disclose. There may be patients who want to tell you their sexual orientation or their gender identity, but they don't want it in their medical record. And I've seen that with our adolescent and young adult patients who are still on their parents' insurance, whose parents are still actively involved in their care. And that should be okay, that it's something that is not documented in the medical record if the patient doesn't want it to be. Now I'll turn it back to you.
Thank you. So let's take a moment, and we'll do this quickly, to revisit one of our earlier questions and get the audience involved once more. Will you now update your patient intake forms to be inclusive of diverse genders and pronouns? Your options are yes or no, or that your intake forms are already inclusive. Well, Dr. Quinn and Dr. Alpert, I think you have convinced this very engaged audience. We have more questions than we have time for, but 87% are going to ask for updated intake forms. I think that's wonderful. And I think, the resources are there. And I think the slide deck is powerful. And the speakers, of course, have been fantastic for you to make the reasoned and patient-centric argument of why this is important. But with that, let me turn it back to Dr. Quinn to wrap up.
Yeah, this is fantastic information. Also, given the fact that roughly, 9% are already inclusive.
Yeah.
So I'm going to skip kind of quickly over these slides because I'd rather address some questions. I'm really just kind of repeating things that I've already said. But again, it's important that the whole entire staff be trained. And staff includes anyone that a patient may encounter during the course of their visit, the use of affirming language, and having support, buy-in, backup of leadership at the very top in order to make this happen.
Right. Okay, and here's the last polling question. Now that you've listened to this very engaging conversation that even I have learned many things from, will you now do a training or education session with your entire team to make sure your office, your forms, and your encounters with patients are inclusive? Your choices are yes or no, or your team has already received that training and education. Well, Dr. Quinn, to your point, 11% have already received it, and an additional 85% are very interested in taking this to their team, and 4% said no. So I think anything where there's a less than 5% in medical oncology is a win. So I think this is great. Any comments on this, Dr. Quinn?
Well, this is fantastic. I think, it's possible some of the reasons that people are saying no is because they don't have the ability to make that change.
Right.
I'm going to walk away tonight thinking in my heart that they would if they felt that they could, but we're not all of us empowered to make this happen.
Right. I agree. Well, thank you to Drs. Alpert and Quinn for such an engaging conversation. I have truly enjoyed the discussion, and I want to leave our audience with SMART goals, which are action steps and which you can do in your own practice that are specific, that are measurable, attainable, relevant, as well as timely. again, our advice, encourage the leadership to collect SOGI information for the reasons of shared decision making, and for the topic of this conversation, for cancer screenings. Use your cancer screening guidance based on anatomy rather than gender and the assumptions that come along with gender, and then make changes to the environment and the language utilized so that you can communicate that your practice is all-inclusive and is sensitive to all individuals, including sexual and gender minoritized people. So this now leaves us with about 14 minutes to ask questions, and we have multiple. So I'm going to bounce this off to both Drs. Quinn and Dr. Alpert. One question that I thought was very provocative is the distinction that was made earlier between equitable care and equality in care. How should we make that distinction? Maybe I'll begin with Dr. Quinn.
I once saw a cartoon that I think illustrated it best. Everybody needs a mode of transportation. Some people need a tricycle because they haven't yet learned how to ride a bike. Some people need a wheelchair because they have mobility issues. Some people, based on their anatomy, want a seat in a different way. So we all need a way to get around, but how we need that is different. So another example is to say, the difference between the golden rule and the platinum rule. So the golden rule says to treat others as you want to be treated. The platinum rule is to treat others how they would like to be treated. So it's taking the time to find out what this person wants and not assuming that it's the same as what you want or what the patient that came in before them wants.
Having not heard of the platinum rule versus the golden rule, I think that is wonderful advice. Dr. Alpert, I'm going to ask you a series of 2 questions now. One person asked, is it a good idea for providers to host clinic days that are special or specific for LGBTQ positive patients, or would that be considered an exclusive thing to do as well?
That's such an interesting question. For a lot of my life, I actually got my healthcare at an LGBT health center in New York called Callan Lord. And I can say for myself that it was really a very beautiful experience to be in a clinic that was staffed by other sexual and gender minoritized people. And I know that, in multiple clinics that I've worked in, there has been a day that trans people come and get care. And I think the idea there is to create more of a sense of safety. So I think that it's a complicated question. I mean, in an ideal world, we'd all be able to share space in a way that was safe. But I think that if you're in a clinic and you don't feel like SGM people are going to be safe, then I think that's one way to try to ensure their safety, is to create a separate day to see people. But I think it's very context specific.
Yeah, I think that's a really nice nuanced answer. The second one concerned a school nurse who has made it her mission to address all students as students and not as boys and girls. And she wonders, are there organizations that can offer the support for young non-binary or trans people?
There definitely are organizations, and if there's a way that I can get you the information afterward, I'd really like to. There are definitely support groups across the US for parents of trans and non-binary students, and also organizations for young people. So if there's a way, I'd love to provide you with that after the.
Okay, and then I'm going to answer this question first, but then I would love to get your thoughts on this. Someone asked, do people who have undergone gender-affirming reconstructive surgery have an increased risk of cancer? And the way that I find this question so interesting is because you are comparing that group who are on gender-affirming hormone therapy or had reconstructive surgery to a control group who haven't. So your cases would be these folks on gender-affirming. What is the appropriate, quote, control group? Is it cisgendered men, or is it are cisgendered women, for example. So if you take a trans female on gender affirming hormone therapy, who do you compare them to? And in my take, simplistic maybe, is that they see themselves as women. They're on their hormone therapy to be seen as women. So the natural place to compare them to is women. And it's a very interesting issue. But what are your thoughts on this, Doctors Alpert and Quinn?
So I think the question of a comparison group is pretty complicated. In general, when I'm trying to use a comparison group of cisgender people, I compare to cisgender men and women for whoever I'm comparing to. But I think it is really difficult to make those comparisons. And I think a lot about a study that was published about a year ago that looked at breast cancer risk in trans women on hormone therapy. It was a retrospective study. In other words, they looked at data that had already been collected and just looked at rates of breast cancer in transgender women versus cisgender men versus cisgender women. And the reason that I think about the study a lot is because it got a huge amount of public attention, because I think they had a number like trans women are 46 times as likely as cisgender men to have breast cancer, which is a very alarming statistic. But if you look at the study closely, you'll see that the rates of breast cancer among trans women were lower, significantly lower than cisgender women. And regardless of hormone therapy, if someone has an increase in breast tissue, it makes sense that they're going to be more likely to get a breast cancer. So,
I think that's why I have the issue, is because it's the nuances of a scientific discussion are often lost in the headlines that we have in the news.
I agree.
Dr. Quinn, any thoughts on that?
No, I was looking at the question and I read it a little differently, and I think it's a more nuanced question, because it isn't just about the surgery or if it's surgery with hormones, but it makes me want to bring up a point that I believe Dr. Alpert alluded to early on, is that increased cancer risk that may or may not be present, I think the jury's still out across sexual and gender minority groups, is not because of someone's identity or orientation. It's because of the associated risk factors that even a cisgender heterosexual person has an equal cancer risk if they are engaging in those behaviors. We do know that some of those increased behaviors, like potentially, that are associated with stress, and stress is associated with stigma. So if every day you go out and there's a lot of microaggressions around you, and you can't find a healthcare provider and you can't find employment, you may be more likely to go home and smoke cigarettes and drink. But it's not because of your identity that your cancer risk is being expressed. It's because of those behaviors that you're doing that are the same as, again, a person who identifies with the sex that they were assigned at birth and a person who's in a heterosexual relationship.
I think those are both really, really good points, especially because, again, the nuances of the conversation is as important as the nuances of the interpretation of the results. And it really behooves us to be transparent in either case of what we are, quote, saying. Now, someone also asked, in a busy clinical practice where you do want to do this, what do you say to the colleagues who are wondering how to incorporate pronouns when they know this is only going to happen rarely in their usual clinical practice, that they are aware that they'll only see someone in this community rarely?
Well, I think an important point to make is that it's going to continue to be rare that we know about sexual and gender minoritized people if we think it is. Like, if we do not ask, we will not know.
Right.
So I think that it may actually not be as rare as that person thinks. And I also think that it's pretty quick to say, like, hi, I'm Dr. Alpert. I use they, them pronouns. How would you like me to refer to you, and what are your pronouns? And if that gets complicated, you can kind of sidestep and talk about other things. But I think it opens a door that probably more and more people will walk through over time.
Right. I want to just read out 2 comments because there is so little data, as we've talked about, on the intersex population. 1 in 2,000 are born intersex was one, and that language is essential, and that intersex referred to as a condition is an example then of a microaggression for the patient's own experiences. Again, bringing out that, asking patients who they are, how they want to be referred to, and also watching how we, our own language are all really important things, with the sex and gender minoritized community, but, with all of the patients we treat, especially in the context of a disease like cancer. All right. So we're running out of time. So if you have colleagues who missed today's live program, this activity will be available on the Oncology, Infectious Diseases, and Education hubs on the CME Outfitters website. These hubs also contain a wealth of additional activities and resources for clinicians and for patients. I personally would like to thank Dr. Alpert and Dr. Quinn for joining me today. And I want to thank CME Outfitters for their assistance in developing today's program. I wish we would have had more time to talk about this and also to gather in person, but I hope you find that this program delivered in this platform was as engaging as an online virtual learning event. To request our credit for today's activity, please click on the Request Credit tab to receive your certificate. Again, I'm Dizon, and thank you so much for joining us. Stay safe, and thank you again for providing the best care you can to your own patients.